Don't forget. Good evening and welcome. This is the second webinar in Formed Families Forward's Winter FASD webinar series, and that is a mouthful. I am Stacia Stribling. I am the Deputy Director of Formed Families Forward. I'm joined with Kelly Henderson, our Executive Director, and we have two phenomenal presenters this evening. Before they get started, I am going to just give you a little bit of background about Formed Families Forward for those of you who may be new to our organization. Sorry, share those. All right, so tonight you are here for understanding the diagnosis of fetal alcohol spectrum disorders, or FASD. And we're going to get to that right away. There is the link to the slides, and Kelly has dropped that into the chat, so you can access the slides now if you'd like. For those of you who may not know, we are Formed Families Forward. We are a family-led nonprofit located in Northern Virginia. We support foster, adoptive, and kinship families who are raising children, youth, and young adults with specialized needs. We also work with family-serving professionals, educators, therapists, folks like that, social workers. And we do that by offering some free trainings. We do free consultations for families. We have events. We have an amazing resource directory on our website where you're able to find providers and other resources to help you along the way. We have peer support groups. We do virtual trainings, and we are also the family partner to the Virginia Tiered Systems of Support, or VTSS. Some of you might know that is MTSS. That's a project of the Virginia Department of Education, and we are the family engagement voice on that project. If you would need a certificate of attendance for attending live, we can only provide that certificate for those who are here live, not if you're watching the recording. Kelly is dropping in the chat right now the email for our amazing administrative specialist, Veronica Ferris, and she is the one that you should email at the end. She does not automatically send out the certificates, only to those who request. So be sure to request if you need that certificate. So as I said, you are in here for the second in our webinar series. We have two more coming up next Tuesday. We will be discussing the role of occupational therapy in supporting those with FASD. We'll have some folks from the University of Washington, Seattle. They are occupational therapists and researchers who will be talking about that. And then the following Tuesday on the 27th, we will be talking about FASD Virginia, which is a new resource that we have developed for folks specifically living in Virginia to be able to find resources around FASD. And I'm really excited because our presenters today, Ali and Stephanie, are a very big part of that web development. They have been collaborating with us on that project for a while now. So we're really excited to get that started. You can also view last week's recording at that site on the slide, and I'm sure Kelly is dropping that in the chat as well. That is the recording of the earlier webinar. Last week we did FASD 101. It was sort of understanding symptoms and strategies for both home and school. One of the things we see a lot with FASD are some big behaviors, and we're really excited to be able to offer a course, Raising Kids with Big Baffling Behaviors. Our colleague, Melissa Lebling, who is on right now, she can wave to you, is going to be teaching that course. She's certified with a program written by Robin Goebel. This is a course that does cost because we do have materials and copyright issues using Robin Goebel's work. So while most of our services are free, this one does have a cost associated. And Kelly's going to drop in the link where you can register for that. It is going to be on Tuesday evenings from February 3rd to March 24th, 7 to 8:30 in the evening. We also have upcoming, mark your calendars, for Saturday, April 18th. This will be our big Spring Forward Family Fun Day for foster, adoptive, and kinship families. It is going to be at the GMU Science and Tech Campus in Manassas from 8:30 to 2. We have Melissa Corkum, who is going to be doing our keynote address. Some of you may have read some of her books that she's written. She's going to be talking about how to develop really powerful relationships with your kids, even when things seem hard. So I think that's a really powerful topic. And we've got some great breakout sessions, and children will be involved in some programming at both the Edge and with Camp Soraka that day. It's just a great family event. We serve lunch, great time to connect with other families and to learn a lot from professionals. We do offer support groups, as we said earlier. So our Formed Families Together support group meets twice a month, and our amazing Melissa Lebling leads that group. The first Sunday of the month is virtual, and the third Wednesday is in person in Fairfax at our office. Kelly is going to drop the link to register for that. You do not need to commit to come to both of those. So if you're kind of far away and you'd just like to do the virtual, that's fine. And it's a drop-in when you can. Again, it is free of charge, and it's a peer-to-peer model. So Melissa has a lot of life experience and a lot of professional experience in being a adoptive and foster parent. So it's just a great space to be heard and to connect with others. And then finally, we have a youth support group coming up. We have typically done a Stronger Together group for older 14 and up. And we have decided we're going to try something new this semester and do a life skills training class for youth. And we're going to focus on students in grades 6 through 9. It is going to be in person in Fairfax. At our office. It is free of charge. We're going to do it for 8 Tuesdays in a row from 5:30 to 7, February 3rd to March 24th. It is free to register. We serve dinner. We do ask that regular attendance is required. We're going to be using the BOTVIN Life Skills curriculum with that group. So there's going to be some really great stuff going on. So if you have a child in that age range or know of someone who could benefit from that, you do not need to be foster adoptive kinship in order to take part in the youth group. You just need to be someone who could really use some help with some life skills. So, all right. That is it for now. That is our final slide for later. I'm going to switch us over. And without further ado, I took more than 3 minutes. I'm sorry, Ali and Stephanie. Okay. I am going to let these amazing women introduce themselves and get started on understanding diagnosis.
Thanks so much. We are so happy to be here. Thanks for spending your Tuesday, right? Tuesday night. This is a hard time. So thanks for being here. We are thrilled to be able to spend some time with you. We're very thankful for Formed Families Forward and all the work that you're doing for families. So thank you for that. My name is Stephanie McNerney. I am a pediatric nurse practitioner at UVA Children's.
And I'm Ali Sturgill. I'm also a pediatric nurse practitioner at UVA Children's in our developmental and behavioral pediatric clinic.
Can go to the next thing. So boring stuff first, we are, I guess that's not boring, it's important, but we are an FASD affiliate along with Formed Families Forward. Tonight we're going to use, we're in developmental medicine, so we're going to use peer-reviewed journals, the American Academy of Pediatrics, Proof Alliance, and then I need to add Dr. Mela Mansfield's Clinician's Guide, which is just so good, and I've learned so much from him. Lived experience, of course, and no financial disclosures. I wish there were, but there are not. So, oh, they're so cute, aren't they? Those are mine, though. So, okay, so we, as the science about brain development and relational health has really taken off in the last 20 years, so has sort of the practice of, developmental medicine. And I really believe that who we are as people and how we show up to our families in clinic is just, it's a bi-directional process. And I think it's important to kind of be aware of those things. So, I come to it with being a mother, a daughter, a sister, a friend. I am a foster and adopt parent to a child with FASD. and have 2 other kids with neurodevelopmental disabilities. And I am so thankful for my colleagues like Ali, who do not have children with FASD and can come a little bit fresher to the work. She is our child's provider, and I think of her every night when we give our clonidine, and I think of her during the day when we give our stimulants, and are able to stay in school, and we sleep now. But I really am so thankful for people who don't come to this space out of personal interest. It's really because Ali has taken the time to listen to families and what a really complicated sort of life we're living. So thankful for you.
Right back at you.
Yeah.
Okay.
So I'm so glad you guys have had a 101. I know the people showing up are usually quite go-getters and have done some learning already. Just really briefly, FASD, as you know, is a lifelong brain-based condition that actually affects your whole body. You have to have prenatal alcohol exposure to have an FASD. And, you know, generally it's going to affect the way that you learn, the way you build relationships, and the way you live your life. It's really important to understand how the brain works, and that's going to be important in the way that you support your families and your child.
So now we can kind of talk to how we even get to the point of the diagnosis process. And I think understanding some of the red flags may be helpful, and recognizing that this is a big spectrum. So we're going to be talking about a lot of different features that may be present that might tip us off that further evaluation is needed. But you may know someone, care for someone, love someone with an FASD that some of these boxes are not checked, and that's okay. So they don't have to have all these signs for an FASD to be considered, and this information, these features aren't necessarily diagnostic on their own, but it's just helpful to understand at what point do we think, let's seek some specialized support. So when we think about the prenatal and early history, we're looking for, a red flag would be known or suspected alcohol exposure during pregnancy, and that's any amount. Could be binge drinking, could be regular use, limited or no prenatal care, premature birth or low birth weight, report of neonatal withdrawal-like symptoms, so, really difficult feeding in infancy, tremors, irritability. We also want to be aware of any growth or physical features, so they might be subtle or they might be absent, but we are looking for, maybe some history of poor growth after birth, and that could be growth of the head, poor weight gain, poor length development. There may be some facial features, which you probably learned about last week too, but we're looking for a smooth or flattened philtrum, which is then the distance between the nose to the upper lip, may have a thin upper lip, and may have some of those short eye openings or the palpable fissures. There also might be other minor physical anomalies like atypical ear shape, some joint stiffness we can see that might be a red flag, and things like heart murmurs. And as you probably talked about last time, you don't need to have the facial features to be considered, but we are looking for them, and that could be a red flag. When we think about developmental delays, red flags could be history of speech or language development delay, even motor milestones, so late walking, late sitting, coordination challenges, little people that seem very clumsier than you'd expect. And, even things like learning differences that aren't explained by IQ alone. It's that uneven development that can be a big red flag, right? Where some people have some really nice relative strengths, but these unexplained marked weaknesses in others. When we usually think development kind of progresses across all the different domains, speech, gross motor, fine motor, social, emotional, they usually go like this, but when we see things that aren't quite lining up, that can be a hint to us to look for more. And then as we think about some cognitive and learning red flags, are these kids, adolescents, young adults having trouble with attention, focus, task completion? They might have some challenges with memory. So, most notably, like working memory is a challenge often. And this understanding of cause and effect and more abstract concepts like time, money, punishment. And we might just have another red flag like poor academic progress despite intervention to help with instruction, and some challenges with generalizing learned skills in new environments. So those are kind of subtle things that maybe our educators are more aware of. And then the next one, yep. So there's more red flags because they're so diverse. But there might be some behavioral and emotional signs.
There will.
That
might.
These ones will be present. These ones will be present. But it can look different.
Yes.
So there might be some challenges with like regulating your mood. So quick to temper tantrums, rapid mood shifts. Kids can seem younger behaviorally than their same age peers, or we'll talk about dysmaturity later. A red flag can be, trouble learning from your consequences or learning from punishment. And anxiousness, low frustration tolerance, difficulty with transitions or change in routine. Executive function problems likely will be there, like some of the mood regulation. And that's looking at kind of features of ADHD. So difficulties with planning, organization, time management might be really hard. Challenges with following multi-step directions. These are kids, teens, young adults who might just need a lot more reminders to do daily tasks that you wouldn't expect for a child their age, even just for self-care. Social and adaptive functioning red flags can include, difficulty understanding social boundaries, social cues. They are a lot more vulnerable to peer pressure and peer manipulation. Can be eager to make friends, right? But struggle to maintain those friendships. And we sort of talked a little bit about that poor daily living skills, but like hygiene, safety awareness, money management can be hard. And these are individuals who just seem like they need more supervision than their same age peers.
And I would say another red flag is the befuddled parent. What is this? Please help me. Like, what is this? This feels just so different than anything I've experienced. So just sort of that quality of confusion that can come from caring for somebody with such a diffuse brain difference.
Yeah, and I think, there's no true line for this, but what we hear probably, I know I do a lot, is they are just consistently inconsistent, or they know better, but they still can't do better. We hear that a lot. And then that mismatch between the appearance and the ability can be really frustrating for the child and for those around them, and that can be a red flag. So, they struggle with comprehension, reasoning, follow through. And these kids and young adults, I know it's a whole lifespan, but they can be labeled like lazy, defiant, willful, rather than just talking about how they're neurologically affected. So we consider, and also thinking about the family piece, right? If there are other known siblings with an FASD, if there's known family history of drug use, alcohol addiction, and they may have other ununified diagnoses present, or family members with ADHD, ODD, anxiety, learning disabilities, and other things. What we're looking for when we think about these red flags are there patterns, not just a single symptom? Is the difficulty persistent? It kind of goes across different environments, despite appropriate supports. Is there a discrepancy between, assumed intelligence and real world functioning? And is there, suspicion of prenatal alcohol exposure or confirmed alcohol exposure? So those are all things. It's quite varied because this is a whole brain body type of spectrum, but these are all things that all of us involved in the care of babies, kids, should be thinking of to prompt the next step, which would be evaluation. So diagnosing, we get those red flags, referrals are sent for further evaluation. The challenge is, and the diagnosis is really for several reasons. First, prenatal alcohol exposure is often unknown or undocumented, especially for children who are adopted, in foster care, or whose early life history is incomplete. But that lack of confirmed alcohol, just remember, it does not rule out future FASD diagnosis. The second thing that can make it tricky is that FASD often overlaps with multiple other diagnoses. So these are kids who may have ADHD, known learning disabilities, autism spectrum, trauma-related disorders, mood disorders, and people with FASD can receive multiple of these diagnoses over time. But what we want to make sure is that we're able to have someone step back and look at the big picture. I often think like there's so many little stars in the sky. ADHD might be a star, ODD might be a star, and sometimes they're just stars in the sky. And other times we need someone to look and be like, is there a constellation? And for these kids, it's that unifying line, right, that we need people to be aware of and look for. And then the third thing is that a lot of kids have uneven skills. So it can be hard to detect some of this because, they may sound very verbal and are bright, but they struggle with daily functioning, emotional regulation, cause and effect reasoning. And that can lead the adults in their lives to overestimate their abilities and underestimate the need for support. So, do next.
So lots of complicating considerations. The majority of the kids I see have the other layer of foster care adoption, and then obviously trauma and attachment disruption. So, those things affect your brain as well. So that can be kind of complicated. I think there's lots to talk about here, but I think the take home from that long list of red flags is that it should always be on the differential for our providers. I think we are pretty much there with autism. People are very aware of autism. They're always thinking about, could this be autism? We need to get there with FASD, that a kid comes in for an ADHD rule out, and FASD needs to be on the differential until it's not. And we are pretty far from that. And speaking to the last, kind of point there, limited awareness in the medical community, it's really disheartening, I know, guys, to go to people that you just think should know about FASD and they just are not thinking about it. They're just not really into, kind of digging more. So that's a real barrier at this point. We are working on it, right? But I think the future is bright, but there is still such a knowledge gap and just kind of like you need people to step into this space like Ali and be like, I'm going to figure this out. I'm going to learn about it. And I'm going to be thinking about it because it's so, so common and so, so impactful, right? And, really in our world, so most of our diagnoses are behaviorally mediated. There's not blood tests, there's not biomarkers. FASD happens to have one biomarker, which is the physical features. 10% of kids, 10 to 20% have those. So that's helpful when it's there. But most of the time we are looking for that pattern recognition, right? But there are slam dunks out there, and we really need our pediatricians to be able to make those diagnoses so that we can see the more complicated cases. So again, there's so much education out there right now. So kind of ignorance is a choice at this point for providers, so we really do need to get to a different spot with that. Obviously, foster care and adoptions, it's a hard thing when you just can't get that information. I've called many a bio parent and asked, even if they haven't been in their care for many years. And I don't know if I've ever had somebody get offended by asking these questions, because even if kids are not caring, even if parents are not caring for their kids, they still love them. And so if you bring it back to like, we just want to help the kid, most parents, even if they're not able to be a forever everyday parent, are gonna be willing to at least discuss it. So yeah, so it's rarely documented, right? I can't tell you, one of my main clinics is early development, so I see kids 0 to 2, and newborn records are very quick to put drug exposure, right? There's, we test for drugs, we get excited about it, we judge people for them, but rarely is there even just sort of like, not rarely, we're getting a little bit better, but no alcohol. Like, people have asked the question. I just want to see that somebody's asked the question. Of course, a lot of our patients that we're seeing are already child welfare involved, and so that's a really sticky place for a family who's already kind of within that monitoring system, to be honest about that. I've tried to get CPS to kind of tell me, would you ever go back and really hold that against a mom, and they said no, but nobody can tell me that that's actually like a standard practice. Providers don't want to ask about it. It's awkward. Again, we just need to be bold. Yeah, I think all of this we've kind of said. Yeah, we can go to the next slide.
Well, I did want to mention, so something that I think is kind of interesting in the documentation of alcohol, again, because Stephanie mentioned no one's asking, no one's documenting. The American Academy of Pediatrics pretty recently came out with a paper that did document 6 accepted criteria for prenatal alcohol exposure documentation. So there are more concrete understandings of what that looks like.
And I would say very rarely are you going to get that level of disclosure. Usually you're going to get a yes or a no and a when, generally, and that's as good as it gets. But
it's nice to know we're like moving towards
Yeah.
something. So just for Black and white people, for me, sometimes I'm like, I like to be able to check a box, and now there at least a box exists to think about that part. But getting down to it, you've seen the red flags, you've gotten your referral. Who are you going to meet in this process for diagnosis? And ideally, it is a team sport. And I say ideally because every clinic setting, based on where you are and what resources are available, might have a different cast of characters. It affects multiple areas of functioning, and so it's best if we have multiple different people thinking of different facets of the brain, the body, and behavior. So you would hopefully meet a developmental or behavioral pediatrician or nurse practitioner, a psychologist or neuropsychologist, and their role is to assess cognition, executive functioning, learning, memory, adaptive skills. Your child might see a child neurologist, just depends on where they are and what some of the concerns might be. We often send families to genetics, and by often I mean we usually do, to rule out some genetic differences if present. So they will probably be part of the team, if not at the initial visit, they'll be part of the team, potentially at follow-ups. And then we really lean on our speech therapy, occupational therapy, and physical therapy sometimes for PT, because they do a great job thinking through, sensory processing, motor skills, adaptive skills. And then also really notably, a part of this team who you might meet on that day would be the social workers. They help kind of navigate and connect families to services. And also part of the team are the caregivers and the families. I think they're an essential team. Without them, the concerns and lived experiences wouldn't be able to capture the whole picture when shared with the people trying to interpret behaviors. So families are pretty vital. So I'm not really great at graphics or PowerPoint, but this was my attempt. So when you're coming to the evaluation, paperwork. We're going to ask for a lot of information from you guys. We're going to be reviewing medical history, birth history, prenatal history. We're going to be asking for forms to be completed, and we'll talk about that a little bit. And it might take multiple appointments. I think that's important to note too, is there are some children that we may meet, and with some of the prep and the information, we're able to make a medical diagnosis of FASD on the first day. I think that's more rare, but just kind of buckle up. You may not get the answer when you come in, but it kind of starts the ball rolling. You're gonna have to bring all the paperwork. We recommend families write down their concerns. You know, I would say like keep a note in your phone of the things, the behaviors, the birthmarks, like anything that jumps out at you that you want to make sure we think through that day. Like write it all down, and don't be afraid to pull out a notebook or pull out a phone or a voice memo that you've recorded. Like that information is so important, and you know the child is the star of the show, but families are their chauffeurs, their posse. So it's important that everyone has a voice there. And be honest. We don't, when you talk about the things that are hard, you can't scare us. I think don't try to downplay things. It's okay just to be honest about what's difficult and how it's difficult and how it's impacting them and how frequently, and then even preparing your child for the visit. Explain that we're going to be doing things to help adults understand how their brains work. It's not pass or fail. Let them know it's okay to ask for breaks and that they're just expected to do their best, not expected to be perfect. These visits are pretty long. And so, no matter where you're seen, it's going to be probably over an hour to 2 hours, maybe even longer. So encourage them to ask breaks. Sometimes that looks like bringing a visual schedule or having a code word, and even talking through like what to expect. So on this is one of the visual schedules or social stories, that we have just of our clinic. Like we're going to get your height, your weight, your blood pressure, your head circumference. The room will look like this. This is kind of what it looks like. And I'm actually a model in one of those since in my child. So take a close look. It's a good one.
And feel empowered. If you know something, if your kid hates their blood pressure, feel empowered to ask the clinic, like, can you guys do that after? Like really, you know your child best, and we want it to be successful and for them to feel comfortable. So often, that takes you kind of saying, this will go better for my kid. So feel empowered to make those little modifications. Okay, so we're at 7:34. Okay, so medical workup. We've talked about how important, of course, a pregnancy, birth, and family history is. We want to, ideally, we know all the things about that history. Of course, we're always going to get a head circumference and look at growth charts. Ideally, we have records from the pediatrician as well, so we can see kind of the trajectory of growth. It's not, you can't trust like a single plot. You kind of need to know where it's going. And there's lots of kids that start off microcephalic. This is one of my favorite things in clinic. They start off microcephalic and then they get in a nurturing, safe environment, and their brain grows, like literally it crosses percentiles, and it's like 20th percentile, and they're no longer microcephalic. But of course, we needed to know that they started out that way. Physical exam, a lot of our physical exam is not hands-on. It's really, we do a ton of observation, but some of it, does take some handling. So the better to do after 1 year is really speaking to the facial features. You kind of need to get rid of the baby face, the kind of flattened hypoplasia that many kids have, to really kind of adequately judge that. But that's just a caveat. We do a really good neurologic exam, and I mean, these kids have abnormal neurologic exams. They just do, and they're subtle, right? So they're not these really focal, obvious neurologic differences. They're kind of this constellation of what we call soft signs, which are things that are brain linked. They're symptoms of a brain difference, but they don't necessarily speak to a focal injury. We look at skin, subtle differences. Lots of kids have, differences in their digits, long, thin fingers, ear things, as we've talked about. We're doing a lot of observation of just their behavior in clinic. My sort of most common experience is that these kids actually do great and do not do any of the behaviors you're going to tell us about in the clinic. They are anxious, and so they're kind of holding it in. So we're going to believe you. So just say that. But there's a lot sort of quality stuff that I kind of can see often. I usually either ask a child to draw a picture or I bring in toys. And these kids usually do not know how to start playing. So they need you to help them start, which is always very interesting. Their play is often pretty simple. It's not really robust in the imaginative pretend domains. They seem like good eye contact. If it's not great eye contact, often it's kind of because it's anxiety. They often seem to be listening to their their parents talking about their life, like they're vigilant to like what's going on, but they don't seem to be comprehending it. So many kids the parents like saying some really hard things. You're like, I would be devastated as a child to hear this. And they're just sort of like, not processing it. So that's pretty common. I love the speech and language differences in kids with FASD. So often there's really precocious words used, different way to say things. Like my 3-year-old, in the middle of the night asked me to make her a charcuterie board. And you're just like, what? How do you know that word? Lots of pronouns that are mixed up. Like usually it's a pretty, they, are pretty verbal, but they have some disorder that you pick up on over time. And then the processing delay for sure, just sort of this sort of, pause and all the things that are happening is pretty common. You can go to the next slide, thanks. So a brain MRI is not diagnostic, and it's not routinely ordered. There might be some instances where we do order it early on. Again, so in the research space, there's all sorts of robust data about documented brain changes. In the clinical space, we're doing a sedated brain MRI if they're not an infant, and we're getting some structural information. So not necessarily how the brain communicates or functions, but we're getting sort of the architecture of the brain. If we're going to see something, it's going to be usually volume loss or midline defects, corpus callosum, cerebellum, basal ganglia, sort of white matter injury. So there's some things that are kind of often seen, but again, you got to realize like radiology is also just an interpretation of an image. It's subjective. And so you need radiologists that are used to looking at little brains because they're so different from adult brains. And so that's a plug for getting those imaging done at a pediatric place for sure. And you want anesthesiologists that are used to little airways as well. So that's the decision tree, is the sedation it takes to get the brain MRI, not the actual test. There's recommendations to not do elective sedation on kids under 3. So if we don't think it's going to change much, we're going to try to hold on till after 3. And then it's a shared decision. Some parents are like, I want all the information, let's do it. And some are like, I don't really feel like it's worth it. If the kid's been stated a time for other reasons, we're not going to really want to state them again. So it just can be varied. Of course, we've had some kids that have had history of non-accidental brain injuries, and then they come in for an FASD, and so we're like, let's, they have some reason to maybe have, so I was told by my mentor, all these kids deserve an MRI at some point. They just do. Like they're gonna, and ideally you're waiting till they can lay in the scanner and not be sedated. I don't know, right? I don't know if you guys have had a brain MRI, but it's pretty noxious. It's very loud. But I do think getting a brain MRI before late adolescence makes sense to me. I'm going to order it if you see me, because I think it's, helpful information. Seizures will buy you a brain MRI, and then cerebral palsy, which is a motor diagnosis. We may or we may not order a brain MRI, it just depends. Genetic testing, kind of went over that. So within the last 5 years, the microarray, the chromosomal microarray, which was kind of better at looking at large differences in the gene makeup, is now been replaced with the whole exome sequencing, which it's amazing what it picks up on, just much smaller, differences. So it's standard to send any kid with a global developmental delay, hypotonia, microcephaly, macrocephaly, to genetics for assessment and then pursuing testing. So that's something we're just going to do. Oftentimes, it's helpful. Like if kids in foster care, I'm going to kind of do that soon because I want the kid, as they are working on the permanency, to have all the information. So again, there's just reasons why we're going to go for it a little bit faster.
Stephanie, there's a quick question that didn't
Oh,
get
yeah.
to the whole group in the chat, and it was on a slide or two back, you were talking about looking at the skin. What is it you're looking for when you're examining the skin?
Yeah, so different. So neurofibromatosis is on the differential for learning and attention issues. So those kids are it's kind of the differential. So if you have a kid with cafe au lait spots, which are hypopigmented spots, that's gonna give you some information. You're looking at palmar creases. You're looking at birthmarks. So just some genetic syndromes have skin findings.
That would help rule out.
Yeah, so not necessarily with FASD, but yeah, thanks for asking that.
And this will just touch on fast. It goes back to my beautiful graphic of just a stack of paper. We're going to be looking at a lot of screenings to assess behavior, development, and social skills. Look at IEP if it's available, any therapy notes, and then we may review and request sensory profiles, speech and language evaluation, and then like a visual perceptual evaluation by motor. So we'll just talk about FASD across the lifespan, and we'll do that kind of quickly so we have some time for things at the end. The important thing is our brains are neuroplastic. We're going to see different things. The sooner we can intervene, always better to put different supports in place, but it's never too late.
So I feel pretty passionate about this. I hope that we move towards diagnosis before 2. Like I really feel we've moved towards earlier diagnosis in autism, CP. We need to be there with FASD. The brain development of a 0 to 2-year-old, 1 million neurons are firing per minute, right? So like per second, per second. It's crazy. So if you just think about the weighting of this, how much brain development we're waiting to see how this goes. And I just think I'd rather be wrong and call it early than miss that window of time. Okay, so what you're going to often see is regulation challenges, often feeding difficulties. And again, if you don't have disclosure of alcohol, a lot of times a really good history is going to give you these little signs. They couldn't, they needed a slow flow nipple. They needed a lot of cheek support. They needed pacing. Like you're going to get these quality reports that are going to give you some information. They are often having low tone or high tone, which is, again, tone is a brain symptom. It's not a strength thing. Oftentimes they may be able to do the thing, but their quality of movement is different. So maybe they're tremulous, maybe they're just sort of awkward. Signs of delayed integration. There's so many infants that can only do kind of one sense at a time. If you're assessing hearing, they literally can just do that, and they can't really integrate those other senses. So there, a lot of times there's really like discrete senses being used without the integration. And yeah, oftentimes there's early motor stuff, just dealing with myelination patterns that development that happens over the first year. We've said this: uneven development, processing, sleep, you guys, isn't that such a big thing? These kids, their sensory profiles are complex. They're avoidant, they're low registration, they're seekers, they're just all over the place in the way that they're kind of getting information from the world. And the cool thing is that we have all this brain knowledge now of why that is. There's actually, we know why. Emotional and behavioral differences. We're breezing this, you guys, because we want
Yeah. So I feel like we've talked through kind of a lot of this, so we can sort of skip to the next one if that's okay. And even school age, we touched on this a good bit, right? Memory, attention, those ADHD symptoms, social vulnerability, and then more than impulse control, decision-making difficulties. We might see more anxiety and depression than peers, and a lot of challenges with, again, that peer pressure, social vulnerability. Okay, so this is kind of interesting because this whole talk we've been calling or referring to FASD as FASD, but when you have a child or you're reading a child's medical report as a school administrator, right, you may not see FASD on that report at all. You might see letters like FAS or PFAS. So we're going to sort of walk through why and what those letters mean, and we'll do it briskly, and you can always send us information about that. But basically the gist of it is it's based on the diagnostic framework that's used. And in the US, there are two main diagnostic frameworks. There's the Washington, D.C. 4-digit diagnostic code.
Washington State.
Oh, Washington State, sorry. Washington, D.C. It's actually on a different coast. Just see if people are still listening. And then the IOM, the Institute of Medicine, the Hoyme-based criteria. So I'll talk through those just briefly so you can understand kind of why the report might look like it does.
Stacey, did you guys do that last week?
No, we did not.
Okay, great.
Okay, so we'll just kind of look at, there's slight differences, but I think it's important to know. So the Washington State, basically it's very research based and research heavy. So it's ranking a lot of measurements of facial features, and it comes out with, and it's a 4-point scale. And so what you come out with would be potential diagnoses of FAS, partial fetal alcohol spectrum, partial FAS, static encephalopathy, which is alcohol exposed, and neurobehavioral disorder, alcohol exposed. So to get this diagnosis with the 4-digit diagnostic code, it's very structured. It's really quite conservative in their diagnosing.
We don't use it.
We don't use it, but I want you to know it exists in case you see those letters on a child's chart. So it's mainly for research. The next one, the IOM or the Hoyme based, that's what we use, and most clinics use that. So you're going to come out with some different letters. We're really focusing on that clinical pattern of recognition, kind of going back to all the things we talked about, like what is the pattern, how is it impacting that child's life and their functioning. So we do look at physical features, at growth, neurodevelopmental functioning. With this, we can make a diagnosis when it's not confirmed. That's more so needed with the 4-digit code. So that's why we do suspected, not confirmed. You're going to see more of the IOM delineations of letters. So it's clinically flexible, and it talks about the real world impairment, and even if the testing is uneven.
And I think there's supposed to be new criteria coming out. We've been hearing that for 2 years, so I don't know where it is, but this was 2016, I think. So I think we're due.
Yeah, it was 10 years ago. So here's just a little chart. So these, one system is not necessarily better than the other. They both have some challenges. And a child may end up getting a diagnosis under IOM criteria, but the same child may not be granted diagnosis under the 4-digit code criteria. Different brains or different names don't mean different brains. Or different needs, they just mean we looked at it in a different way. Okay, next one. And
Oh, yeah. So diagnostic disclosure is an art, and we try to be trauma informed and culturally competent and adoption competent, all the things. We try our best, but sometimes we don't nail it. So, I really focus on the sort of rollout of neurodiversity, neurobehavioral. Just we all have brains, they all work differently, we all have strengths and weaknesses. Avoid blaming birth parents. Yeah, I mean, I don't, it's often not saying your mom drank alcohol, but like you were exposed, you were exposed to alcohol, kind of thinking about that. But having that conversation over time is linked with better outcomes for your kid, being a self-advocate.
And I will add, like, what we found is just being honest and not tiptoeing around it, not just for the family, but for the child. They recognize that their brain might be working differently than the other kids in 2nd grade. But with the mystery of wondering why it works differently can cause a lot of additional challenges to self-esteem and self-worth. But just being honest, like alcohol before you were born made it harder for your brain to do some jobs. It's not your fault. And we're going to find ways to help you. And then we can just touch on just briefly, like the supports, young children, we want to make sure early interventions involved, get speech, occupational therapy, physical therapy, if it's indicated. Teens, we really want to make sure we have strong IEPs or 504 plans, that they're plugged in with some mental health care. And what that looks like later is for young adults is, life skill coaching or vocational support, and making sure through all of this, there are social supports, waivers, support for families as well.
I think an important thing is just, I think so often parents are like, okay, I need my OT to work on the sensory integration difficulties. I need my OT, but you're not going to fix the sensory integration differences. You're going to learn how to accommodate it, right? So I think so often people are thinking that the therapy is going to move the needle, and it's not, right? It's going to give you tools, because it's really about, I think the central thing is caregiver, skills and knowledge. So what if you do have a diagnosis is not made? A lot of times we'll counsel families like, let's treat it like it's FASD. If we're really feeling like this is FASD, but we can't make that diagnosis, well, they're certainly gonna have other diagnoses. I'll tell you that. Like, you're just gonna, but the parenting that you learn around this, the way to advocate for your child, the way to accommodate them, it honestly helps all kids too. So we often will just say, like, let's just move forward. Like, we need to learn some skills to deal with a brain-based difference, right? Delayed diagnosis, yeah. So many strengths.
I know, I feel like all those red flags, I just like, because these kids are incredible. They're creative, they're fun, they're kind, they're silly, they're empathetic. They can do great things, and they do great things. We just need to match their brain-based needs with the supports that we can. And that includes, everywhere they go. But we're getting better at understanding what those supports are and helping kids, adolescents, young adults, reach their full potential. So thank you guys for listening. We have 5 minutes, but you guys, your advocacy truly does make all the difference for these kids.
Can you talk through, so can you talk through social vulnerability? So, the brain, the effects of alcohol change often their ability to read social cues, to really register their sort of effect on people. Their learning, social cognition is really difficult. So they're often really gullible and really trusting. They want friends, but they don't know really how to adequately keep and make friends. So there's just a lot of risk and vulnerability for these kids that is something to really be thinking about. Did that answer it? Sorry, I'm missing the question now, but
Yes, I think you did a good. Oh,
yeah,
Yes,
like for my
that certainly
okay.
helps. Thank you. Thank you.
Yeah, like for my kid, I just asked that she never go to the bathroom alone with a kid, another child, and they had let her, and something happened, nothing horrible, but just those little considerations of like, I'm going to set her up for success. I'm not going to put her in a position where, so thinking about the supervision that is needed, and we're not at the adolescent stage yet, but I bet that is very complicated when kids want independence and you're trying to provide supervision, probably in disguise or something. I don't know, but yeah.
Stephanie, there's a question above that about ABA. Has that been researched, and is it beneficial for kids?
Ew, that's not controversial at all.
Right?
Yeah, so I mean, I think a general take home is that ABA is not evidence-based for FASD. I think it's just not the right framework, right? So, and there has been harm in light of that not being a good match. The one caveat is like people who live in these sort of research source deserts and they have ABA, I will really try to empower the parents to sort of partner with the ABA therapist and like, how can we make this attachment informed? How can we, if you have a really, experienced and flexible and humble provider, they can learn and adapt it. So I think it's not always a no for me, but it's usually a no. I don't know if anybody else has any.
I've rarely seen it be a great fit, but that's not to say I've never seen it be a good fit.
Oh gosh, the medication, yeah, that's the whole thing. We do.
Oh, Matthew's protocol, yeah.
We do a lot of medication management. Ideally, our psychiatry colleagues would come with us on this journey and have some more understanding about the pharmacology, that there's a lot to be wanted there. But when we're getting to Matthew's protocol in terms of what that entails, we really want them to be with a psychiatrist. Does that make sense? Because even neurology would be just a safer, which is hard because oftentimes you don't have that luxury. People don't know about it. I think we are generally gonna make it work for a family. If we can't find that support, we're gonna go for it because it's, the suffering is great. But I hope that answers that question. We're not highly comfortable.
Do you use Dr. Mela's protocol too? That's a great one.
I always share that with families, like start looking at it, sort of like think about the clusters, think about, priority one, what seems like the most impairing. I'm really thankful for that work. It's really, 12 and up is where, but we extrapolate it for younger kids all the time.
Yeah, and that resource can be found on the CAN FASD. I'll see if I can grab that and drop that in the chat as well. I do have a question that didn't show up in the all. Dan, a teacher and professor doing a dissertation teaching students with FASD and autism music. So information on how to teach them. There is a lot of stuff out there, and we've got some. If you go back to last week's webinar, in the resources, I would check out stuff by Vanessa Spiller. She's in Australia, and she has a fantastic book, Explained by Brain, that talks about the different brain domains and how to teach to those domains, how to rethink expectations, whatever those other pieces are, how you use strategies and different accommodations. So that might be a great resource for you, Dan. And there's some others on that slide as well.
Yeah, I mean, I maybe the OT next week we'll talk about therapeutic listening. And I don't know if you guys have ever, yeah, I mean, I'm really interested in that and polyvagal. Yeah, so maybe they'll touch on that. But
Stacia, I do recognize we're a little over time. Do you mind putting that last slide up? And we just want to encourage everyone, in addition to our thanking Ali and Stephanie for their fabulous presentation, feel free to chat in your appreciation or thank you for the reactions that we're getting. I know this was hugely valuable. We kept a strong audience, so I know what you had to say was really, really valuable. We also are going to ask you all who are in the room to complete the evaluation. It's just a quick link. It takes maybe 2 minutes. Stacia just did include a link to the algorithm or the protocol that was referenced earlier, but please do complete that evaluation. Oh, there you
Your hand, sorry.
and that's okay. So many things to share.
Yes.
We do use that information. We will share the information that you share with us with our presenters so they can, improve and grow and all those good things. And we hope to see you a week from tonight at 7 o'clock. Stacia, do you want to give any teaser more than you've already given?
Yeah, so well, we're going to be talking about occupational therapy. So we have some folks from the University of Washington who've worked closely on some grants with FASD United and have done a lot of research on OT and FASD. So as Stephanie and Ali were talking about, the different pieces, they mentioned OT a lot. And so this will really dive more deeply into that approach in supporting folks with an FASD. So it should be some great information. Oops, sorry.
thank you guys.
Sure.
So good
Thanks
to
for
be
having
with
us.
you.
Thank you.
Good night, everyone. Thank you.